If you don't know me, I'm Courtney Schmelsley. I'm the Marketing Director and Foundation Development for the hospital. And so this event is sponsored by the Nemaha Valley Healthcare Foundation. The foundation's been around since 1990 and has hosted several events the past 27 years. The most common one you probably know of is the Foundation the Hospital Golf Tournament that's held in June every year. So our foundation board of directors, which if you're on the foundation board, just raise your hand real quick. We've got a few board members here, which is awesome. We recently did a strategic plan, and in this plan it was determined that the foundation wants to be more active and more involved in the community and start educating the community about the hospital and the needs and the expenses of all the needs and all that stuff. So what we decided to do is we're going to host quarterly educational series like the one we're doing now. So we have this one, and we're going to have one in April and continue on after that. And so with that said, I'd like to introduce Melissa Hungerford. She's with the Kansas Hospital Association. She's the Senior Vice President of Healthcare Leadership. She's been with the KHA for 38 years, and she specializes in rural healthcare. So, hand it over.
Well, hello, everyone. I'm also at the Kansas Hospital Association. I'm responsible for our foundation, too. So maybe I can pick up a few tips from you all. So today, what Courtney has asked me to do is to talk to you a little bit about some of the challenges that hospitals, especially rural hospitals, are facing, and talk a little bit about what kind of conversation folks are having at the national level and at the state level about the future and what the future might look like. We're going to focus primarily on small rural hospitals for the most part. I think you guys fit into that, although you're a little larger than some of the very small hospitals that we have across the state. So we're going to talk a little bit about that, but most of all, questions. If you've got questions, just stop and ask, because this is really about a learning experience, about you finding out what you want to know about. So if something piques your interest, I don't profess to have all the answers, and I will dodge the bullet if that happens. But what I can say is Courtney and others that are on staff will hold me to it. I can maybe find out the answers and get back to you. So we'll just kind of leave it at that. Before we get started, Courtney started by saying some of you are on the foundation board. Some of you are hospital staff. Do we have any hospital staff here? 1, 2, thank you. The guy at the video camera. That helps, thank you very much. I told him I'm not shy about much, but that's one of them. So I'm going to try to ignore him as much as I possibly can. What do some of the others of you have as a connection to the hospital? Are you donors? Are you just interested because you're part of the business community? Just shout out.
I work with a program that serves individuals with developmental disabilities, community-based program, and we are constantly in and out of the hospital.
Sure.
Just with routine things, so it's very important to us.
Sure. Others?
EMS.
EMS. I saw, is that you guys across the way here? Yeah, okay.
I'm the
Probably got the
director
wrong. I'm sorry?
the director of the assisted living next door to us.
Cool, thank you. Others?
I'm with Highland Community College. We have a regional location over in Baileyville, and we have a medical office assistant program and a full offering of allied health courses. So.
Great, we really rely on you a lot. Okay, cool. Well, let's just...
Interested citizen trying to keep our hospital.
That's great, and I'm sure that they appreciate that more than you know. So let's talk a little bit about what we have going here. Didn't really pay attention, Courtney. Is this the clicker?
Yes.
All right. You're going to have to tell me which way goes forward and which way goes back.
We might have to do a trial and error.
Better you than me. I am technology challenged. Well, I'll just use this.
Okay.
We'll go old school. Okay, so we're going to talk a little bit about what's happening at the state level, a little bit about what's happening at the national level, and I'm sure those of you who are watching the news can probably tell me as much about what you think the future's going to be as I can, but maybe I can bring a little bit of clarity about what the questions are that they're trying to deal with. We're going to talk a little bit about some of the newer models that are coming out to maintain access to health care in rural communities. And they look a little different than what we're traditionally used to. And then we're going to talk about some of the key concepts and strategies that folks are looking at that you might hear those terms going forward and might want to kind of pay attention to. So we'll just kind of talk about what they mean who's to know exactly what they mean locally, but those would be the things that everyone will be looking at. So let's talk a little bit about where we are now. I will say one thing. Kansas is one of those really scrappy states. We have a lot of independence and we don't like to be told what to do. So we tend to keep things going the way we want them to go because communities step up, foundations step up, physicians and nurses step up, and you just get the job done. So we have an awful lot of hospitals in the state, and we'll talk a little bit more about that. But we are not seeing the kinds of rural hospital closures that the rest of the country is seeing. There have been somewhere in the neighborhood of 50 small rural hospitals closed in the last probably 3 or 4 years. Kansas has just not had that. The one hospital that we've had closed has been in Independence, Kansas, and I don't know if you guys got the news up here about that. So they're still trying to figure out what they're going to do. But part of the reason that is an interesting circumstance is because, like the rest of the state, there are hospitals very close together. So there are other services available near and for those communities. So one of the things that KHA has done, the Hospital Association has done, is really try to articulate what some of the facts are and what those facts mean to Kansas. The first fact is most of our rural hospitals, where Medicare is concerned, that's the program for our older population, where Medicare is concerned, are not breaking even. They're losing money. And you would think that most hospitals, like Seneca, who are what we call critical access hospitals, who are paid based on their costs, that how could you lose money if you're being paid your costs? Well, what happens is Medicare only allows certain costs, and they carve out other things that they say are not our responsibility. So the Medicare patient that normally comes into the hospital and sees this horrific bill that you see, Medicare will only pay a portion of that, and you're not allowed to be billed for the difference. So that the hospital just takes that on the chin. And that happens with a lot of our public payers. Medicaid is another one that does that. Even to a certain extent, some of our private payers. So many of our hospitals are in the red. Most of our rural hospitals are also supported by their communities in some way. We found that 74 of our hospitals in the state, we have 127 community hospitals like the one we have here. And 74 of those are supported by taxes in some way. Either property taxes, sales tax, sometimes the county or the city will own the building and will take care of all of that, and it's not really on their books. There are a lot of different ways that communities support their hospitals. Another way communities support their hospitals is through volunteers. Especially rural communities use their volunteers to prevent them from having to have paid staff do a lot of that. EMS is a big one. You guys have volunteers?
We used to be, we're now paid service.
And that, hopefully that's more and more, because it's very difficult to run an EMS on volunteers. So that's a 24/7 lights and sirens kind of thing. You got to have folks available. So we know that these kinds of things are really challenging financially our small hospitals. And to top it all off, Medicare continues to make payment cuts every day. As part of the Accountable Care Act, In order to pay for all those folks that were now going to be insured, they had to save the money somewhere else to pay for all of that. So we'll talk a little bit more about what repeal and replace means in a little bit. But that's one of the scarier issues, is we've had all these cuts, assuming that we were going to have a whole lot more people able to pay their own way, and now that may go away. So one of the things that we know, that federal and state governments who are challenged for money aren't going to pay more than they're paying now. So even as costs go up, now we're in that bind of we're going to have to make do pretty much where we are, or even with less. Another thing that is true about Kansas, and frankly most of the country, is that we rely on the acute or inpatient side of the hospital to bring in most of the revenue. And those of you who work in the hospital know there aren't as many of those as there used to be. And that's true for a number of reasons. One is we tend to live a little healthier than we did before. Another is we know more about how to prevent those emergencies and those inpatients. Now we still have them, but we know how to keep people out of the hospital better than we used to. And the more and more we talk about population health, and we'll talk a little bit more about that later, and trying to keep people healthy, which is what we're really on the planet to do, we're going to see that acute inpatient side go down. On the other hand, outpatient and clinic services and those things that we can now do on that kind of a basis is going way up. So we are in the process of training new staff, and as they come in, they're much more in the business of getting people out of the hospital as quickly as they can be. Back when I had my kids, you could stay anywhere from 3 to 7 days after you had a baby. That just doesn't happen anymore. A gallbladder used to be, what, 2 weeks, 3 weeks sometimes? That just doesn't happen anymore. So not only is technology and medical care advancing, but we're also learning how to prevent some of the bad things from happening. We do, though, in Kansas, and here's the bad part of it. Kansas, back in the 40s and 50s, there was a law passed called the Hill-Burton Act. And that Hill-Burton Act was like an economic development act at the federal level. And it paid for the building of hospitals in rural parts of the country. Kansas did that really, really, really well. We have small hospitals in pretty much every county in the state. And some of them are not more than 15, 20 miles from one another. You guys are in that circumstance here. So Kansas has more beds per 1,000 population than all but 8 other states in the country. If we were to come down to that middle point and have the average number of beds, we'd lose 2,000 beds in the state of Kansas. That's an awful lot of small hospitals. Now granted, most of the overbedding is also in urban areas. They're much larger, have more of those beds, but even that shows that we're way over. And we don't have near as many admissions in those beds as other states do. So not only do we have lots and lots and lots of beds that we're not using, but we're not using in the process. So that's kind of the way Kansas is laid out. If you look at other states, those hospitals are much farther apart and they're smaller than they are in Kansas. So we know, based on all this, but also looking at the world around us, that the outpatient services will continue to grow, and that as we prevent more disease and are managing that disease well, we'll have fewer use of our acute services. And that in order to keep the traditional hospital the way we're used to it, there are a lot of fixed costs that are going into that, and we're not using and spreading those fixed costs over as many people as we used to. So those kinds of circumstances are going to present a real challenge to us. Now, you all live in a small rural market. You're used to that. You know that the apple market or the grocery store down here, They are every day trying to make sure that they sell enough to keep those stores open. In Kansas, we have 89 of our 105 counties are rural. 36 of them have fewer than 6 people per square mile. It's not a lot of population. That population is going down. So all but a very few of our counties have lost population. And most of those that have lost population are rural. So what we're finding is not only are people moving away, but our younger people are moving away. So the population is not regenerating itself the way it normally does. We know that there's going to continue to be that shift. And we know that the population, we're going to be really challenged to support a 24/7 kind of operation. We also know that our population is aging, and when we have fewer younger folks and the folks that have lived here all their lives age, that's what happens. Your population overall ages. So we have in Kansas, which is huge in comparison to other states, we have 40 of our 105 Kansas population that have almost 30% of the population over 65. And that's an unusual circumstance, which makes us want to be sure that we have access to health care in all of these places, because our older population is not near as mobile as our younger population is. So how do we balance that? We also know that our population is diversifying, not just by race, but by ethnicity, by interest, male, female, all of those kinds of things are changing. What struck me as interesting is we have 7 counties that have really grown in diversification, and 5 of those are rural. I would have thought that they would have been Topeka, Kansas City, Wichita, Salina, some of those, but it's not. It's mostly in rural counties. So we also have workforce challenges. You guys are pretty lucky. You have a thriving medical staff. You have about the right number of medical staff for the population you're serving, so you don't have too many or too few. You're really right at that great place where they're busy and thriving. We have a lot of places where physicians or nurse practitioners or physician assistants, they don't see very many patients on any given day. And I understand today is a pretty busy one. You guys have been pretty busy over the last several weeks, which is great. But what happens in rural areas is it goes like this. We get really busy times, we get really slow times, and we can't predict when that's going to be. And that makes it very difficult to keep your workforce steady. So if you have your pool of nurses and they're pressed to the wall on those busy days, then on those not so busy days, there isn't a lot to keep them busy. And so that's much more difficult to do in a small place than it is in a larger place. So we also, one of the things that rural communities have that other urban communities don't have quite as much is that the hospital and its medical community, all of its medical community, are so interwoven into the economy of the community that you really can't separate them. We're like the 4th largest employers statewide, but my guess is that you're probably 2nd or 3rd here, probably next to the school district or another larger business, but that you're up there really high. And we bring in a lot of cash because all that money from Medicare and Medicaid, which is in essence coming from the federal government, is coming into the local economy, getting paid out in salaries. So there's a really connected expectation that that hospital continues to be a major employer, continues to bring that cash into the community, because without that, nobody buys groceries, nobody needs those other services. So that is a really important thing. In a larger urban community, that's not necessarily the case. So those hospitals are more challenged, but they're freer to do what they need to do for business reasons because they're not so connected to the community. So what that means is we have a lot of things happening. We will continue to have a pressure to reduce costs. You don't want to pay any more than you have to for things, especially drug costs. I happen to have rheumatoid arthritis, and one drug cost me $5,000 a month. Now, my insurance pays for that. I don't pay much. But those are the kinds of costs that drive those costs up, and you'll see that in a little bit. We know that if we continue to rely on the acute part of the healthcare system, that's not going to prepare us for what's happening in the future. That acute part is going to go down, and we'll still need it. We'll still need that emergency response. We'll still need that response when something happens, but we're going to need it less and less. So we can't continue to rely on that. We know that we're going to continue to have shrinking populations, so we just kind of have to understand what that impact is going to be. And we know that most of our really small communities are going to be very much more reliant on their nurse practitioners and their mid-level practitioners. You guys, maybe not. You have a really strong physician base, but there are a lot of communities out there that have one provider. And where there's one provider, that's very often a nurse practitioner. So we know that that's part of what we have to look at in the future. And we all know that even though every community in Kansas is so independent and so proud of its heritage and so hopeful that everything will stay the same, if we don't all work together, we're not going to make it. So we're going to have to cross some of those old high school, who won the 1974 game, or who got the county seat, or whatever in the process. We're going to have to start working together and thinking more as a system or a region and less as a community. And that's a really hard place to be. It causes folks a lot of angst in the process, but like as not, those relationships are going to be really important. And we have to think ahead in that process. So we may not need it today, but if we need it tomorrow, it's almost too late to go looking at what kind of future we're gonna expect. So I think one of the things that I really wanted to talk about in Kansas is the healthcare landscape in Kansas. And the governor just did his State of the State, and he had originally last year cut all the Medicaid rates by 4%. Well, they're already below what it costs to do it, so he cut them another 4%. In the State of the State, he said, well, we're just going to tax hospitals. We're going to use that money to leverage federal funds, and then we'll give that money back to hospitals, and we'll make up that 4%. Well, that tax has to come from somewhere, so it's going to come from the hospital. So in the long run, we don't make up the 4%. So the Hospital Association, and probably the hospital here, is going to ask you to weigh in with your legislators about the things that are going to happen over the next legislative session. We know that that's going to be a real problem, primarily because our budget is a mess. We're well over $300 million in the hole for this year, the year we're in. And no matter what they do related to taxes or other things, that's not going to hit the budget until next year. So how are we going to make up that difference? There are some things out there on the table, but I don't know. We could take a vote here today and put it in an envelope, and it probably won't be what happens at the end of the legislative session. So I don't know that we can predict that. But the State of the State and the budget that was presented yesterday has a lot of moving money around. So we'll see how that all goes. But the bottom line is, as long as the budget is in shambles, the chances of Medicaid being made whole are more and more challenged. One of the things that we did not do in Kansas is expand Medicaid. Most of the states, there are 36 states that expanded Medicaid. We're one of the 19 that did not. Expansion leveraged a whole lot more of that federal medical tax that you all see on your paychecks. So Kansas has lost well over $1 billion as that money has just gone to other states because we're not using it. So we have an awful lot of Kansas who could be covered by Medicaid that aren't, because we haven't raised those limits, poverty level limits that make you qualify for Medicaid. That has a long-term impact, primarily because now what the Trump administration is talking about is some kind of block grant. Well, block grants are usually based on what you've already gotten historically. So because we didn't expand Medicaid, we don't use as much money for Medicaid. So our share is at risk. If we had expanded, we'd be higher and we'd get more of a share of that block grant. We don't know how that's going to happen. Of course, the Trump administration doesn't like Medicaid expansion, so in essence, we're hopeful that they'll recognize that they're really penalizing the states that followed that principle. So we'll see how that goes forward. So on the national scene, I put Tom Price's name next to him. You all know who the top guy is, but the bottom guy is the new Secretary of Health and Human Services, HHS, which is where Medicare and Medicaid live. And so his policies are the ones that we're all anxious to know about. And I don't think he's been confirmed yet, but I don't know that there's much question that he will be. It's just a matter of time. So we know we're in a new era of health policy. Everyone is talking about repealing Obamacare. You've heard that a lot. You've heard the repeal and replace phrase probably quite a bit in the news if you're listening to that. So what they're talking about repealing are pieces and parts of the Accountable Care Act or Obamacare. So the pieces that they're talking about taking away are the mandates that employers and individuals have to have insurance. That is the goal was to have everybody insured so that they would be able to pay their own way when they went into the hospital or to a physician or whatever. And the only way to do that was to make a whole bunch of cuts on the other side in order to pay for it. So they're talking about repealing those individual and employer mandates. They're talking about repealing the additional Medicaid funding in Medicaid expansion. They're talking about repealing the Medicare payment adjustments and keeping things like being able to keep your kids until they're 26 on your own policy. Everybody likes that. They're talking about keeping that prohibition on pre-existing conditions, which sooner or later pretty much everybody's got something that you get underwritten out. And they're, again, keeping some of the what kinds of coverage insurance policies have to have. Not that everybody has to be covered, but the things that are included in that plan. And then they're talking a lot about replacing it with a whole bunch of different things. And I don't know, the ins and outs of all of these, but this is the list of things they're talking about putting back in. So some kind of tax credit for people who do buy insurance and for businesses who buy insurance. I don't know if you all are familiar with health savings accounts, but the ability for you to put money into an account before taxes that would be tax-free. You hear a lot about the legal system and all of the liability claims on physicians and hospitals and others kind of being a little out of control, so they're talking about putting caps on those. And they're talking about Medicaid block grants and the ability of some small businesses to come together and build a pool so that they don't have just such a small group. Nobody knows what's going to happen. The hope is that it'll all happen at once, but that's highly unlikely. So we're left with sort of this challenge. What's going to happen to hospitals and physicians? Are the payment cuts going to be restored before the rest of the stuff is taken away? Is that going to balance? What's going to happen to state budgets? So the expansion states versus the non-expansion states, how they're going to be treated with those block grants. And then what's going to happen to the 20 million individuals who did get insurance through Obamacare that now will have trouble getting insurance? So what's going to happen to the individual? Regardless of that, there's a big difference between the political environment and the regulatory environment. So the federal government manages to keep on moving even when the political tides change. And the Medicare and Medicaid bureaucracy is no different. Before all of those laws get into place, a lot has to happen. So it could be years before all of the repeal and replace stays in place. One of the things that's really important to the current regulators, those are the folks that get their paycheck from Medicare and Medicaid, is that we work on making sure patient care is the best that it possibly can be, that we reduce costs to where we're paying for the right thing, and that we're improving the health of the population as a whole. So before you're a patient, what are we doing to help that process? In our minds, that will go away. That will stay on regardless of what the political tide changes. So one of the things we talked about a little bit earlier, here's just a graph of healthcare costs. So your hospital services are this red line. Here are your drug prescription costs, which are going off the roof. Here is inflation, so this green line down at the bottom, and ambulatory services starting to work back up too. So you can see where the costs are. It's going to be a difficult policy to be able to get those drug prices down. So we'll see what happens with that as we go forward. So before we go on, any comments, thoughts, questions? You just had lunch. Any thoughts? Okay. Well, so let's talk about a little bit about what folks are thinking for small hospitals in the future. In Kansas, we particularly have this problem. This graph shows that we have 30 or more hospitals that on any average day have 2 or fewer inpatient acute patients. Now, any of you with a business sense know that that's not enough to keep that service going. So as we look at those 30 hospitals, what do we do? How do we help them maintain the other parts of their business which are so important to a community? How do we make sure that they can respond to emergencies? How do we make sure that they're there for your primary care needs and that they're there for that chronic care management? Those of us that need services regularly, but we don't necessarily need inpatient care. So we're really concerned about those hospitals. But overall, just so you get a sense, there are about 65 hospitals that have fewer than 5. So we have a lot of very, very small hospitals in Kansas. So in Kansas, a lot of things are happening. One you may be interested in Harper, Kansas, when I first started working for KHA back in the 80s, there were 3 hospitals there. One's closed. There are now 2. Those 2 are about 12 miles apart, maybe 11 miles apart. And they have been battling since probably before the Civil War. Those 2 communities have never seen eye to eye, ever. They were able about 10 years ago to combine their school districts, kind of out of because they had to. And they built a school in the center between those 2 communities. The 2 hospitals have now joined their boards and are working on bringing a new hospital to the center right near the high school and using the buildings in those 2 communities for other kinds of services. They're in the planning process. It's taken probably, well, at least 18 months for them to come to this point. But we're going to see a lot more of that. You all have a challenge. You have 2 hospitals in your county, not all that much farther apart. And I would imagine the 2 communities are pretty attached to the way things go in those 2 communities. But you might be looking at Harper and saying, what can we do together? that may keep us both healthy. How do we do that? There are other kinds of things. There is a grant, like a $12 million grant, that came to KU and Hayes Hospital and about 20 small rural hospitals to really look at how do we serve patients who have heart emergencies how do we make sure that we're doing that best practice? How do we care for those patients and make sure that they're going through the system the best way possible and ensuring that we're preventing any further heart issues? And they are actually showing some really good work by integrating all of their heart-related services between all of these hospitals who are very independent and very different. We're not talking about any kind of ownership or anything like that. That's called clinical integration. So you may be hearing a little bit more about how that is. And I'm not sure whether Seneca's in there or not. Do you know?
Yes.
You are? So a lot of things are happening out of that. You probably have telemedicine. Maybe you have the Avera emergency support.
We're just getting started.
Just getting started of that. That has been a really important initiative for some of our 1 and 2 provider communities. A lot can happen when you come into the emergency room before the doctor, the nurse practitioner can get there. So that telemedicine is really helpful. And they remind you what the protocols are all the time. So there's a lot going on with that. There's a lot going on around how do we get mental health into communities, because we have our regional mental health centers, but we don't have a lot of local services when we need them. So how do we bring that in? There's also something called the Accountable Care Organization, which mostly is happening in the urban areas, but they are establishing regions around those. And the goal there is to squeeze cost out of the system and then share the savings back to the federal government. So they keep some of the savings and they pull the savings back. And you guys probably aren't part of that yet, I wouldn't think. But that could get bigger and more and more. And then there is a primary health center, which the Hospital Association has been working on. And I think that's the next slide. So if we've got 30 hospitals that have fewer than 2 inpatients, how do we help them have a choice? If they can continue the way they are, great. But how do we help communities have a choice to realign their services with what they're using in the community and make sure that they can move some of those resources to things that they're not doing now that they really need to be doing? And so we developed this model. You can't do this now. The laws won't let you do this kind of thing. But this would treat patients up to the time when you have to be admitted as an inpatient. So what we're thinking is that a lot of the bureaucratic stuff that says you can't treat a patient that isn't qualified for an inpatient stay. You can't treat them for very long locally, but there are a lot of things that you could do that are, we'll call it subacute, but I hate to, it's not really a great name for it. But I think of my mom, who's 88. If she had pneumonia, she obviously could not stay at home, but she really may not be sick enough to be called an acute inpatient, but she needs somebody to kind of help her with her medicines, and she can't get around very well when she's that sick. And how do we make sure we can care for those folks? And how do we prevent that inpatient admission if we don't need it? So this model might do that. And there are 4 states, New Mexico, Colorado, Kansas, and Oklahoma, that are working with Medicare to see if we can't pilot that in some of our communities that might be interested. This is not a replacement for small rural hospitals. It's an alternative that communities may be interested in. The American Hospital Association has identified a whole list of things that could be done. Many of them, like our primary health center, you need to change some laws in order to allow them to happen. But they're looking at how do we become more involved in what we call the social determinants of health. We know that poverty and your food intake and all of those kinds of things have a lot to do with your health and your need for the healthcare system. So how do we begin to align services with that? One story that someone told me not too long ago is, they keep seeing this patient, an older gentleman who has diabetes, over and over and over and over again. And he knows what he's supposed to be eating, but he doesn't cook for himself. And so he had no way to get to the senior meal center at lunchtime. So they found him a ride to the senior meal center, and all of his numbers started to come back into line. So those are the kinds of things that communities can do. You're not paid to do them now, and it's really hard to put resources in that without some extra funding. So these are the kinds of things that we're kind of thinking about, and I won't go through all of those. So let's talk a little bit about some of the things you're going to hear in the future. The first one is population health. I don't know if you all have been hearing that in the news. I know in the healthcare media, that's all we hear about is population health. And that is reconfiguring our interest and our thought process from responding to something a patient needs to trying to understand that in the front end and preventing what we can. So being responsible for a population's health. Not just making them well after they become sick, but keeping them healthy and increasing those indicators. And the bottom line is, if a population is healthier, your health care costs are lower. But you don't see that right away. That could be years and years before that cost structure rebalances itself. So you'll hear probably the hospital talking more and more about concepts that relate to population health. Chronic coordination and chronic care management, diabetes, heart conditions, all sorts of things. If you're not staying on top of that along the way, then all of a sudden something happens, something spikes, and you have to be in the hospital. So how do we manage that? How do we help patients get in between all of the different things that they have to do and get to the dietitian, making sure that they're following up on their primary care, that they're getting their feet checked, or whatever it is that is important to them. So you'll hear a lot about that. You're also, if you're connected into the hospital itself, probably consumers aren't hearing a lot about this, is a term called value-based purchasing. And really what that's saying is that large payers like Medicare and Medicaid, even our private insurance, they only want to pay for the right care. They don't really want to pay for the wrong care. And frankly, nobody does. So really they want to make sure that the majority of the care that is being provided has great outcomes, and that you're not paying for care that might not have as good outcomes. Sorry, did somebody say something? Okay. So the first step of that is what they call a bundled payment. And in Kansas, that means that that's really only in 3 places in the state. It's in Topeka, Kansas City, and Wichita. However, those patients, you may share with them because you may have primary care. They may live here, but go to Topeka for some of those higher end things, hip replacements and heart procedures and other kinds of things like that. And then they come home and they may be in your swing beds. So in this new process puts someone like Stormont Vale at risk. So Medicare is going to set a price for all the services that that patient's going to need, not just the services at Stormont Vale. And if that beneficiary spends less, then Stormont Vale will get to keep the difference. If that beneficiary spends more, then Stormont and all the other providers are at risk for that amount. So that bundle, or that bundle of payment, there's going to be one payment for all of those services, and they're still kind of in process of implementing that, could impact folks like Seneca and others. So you may hear more about that. Another thing that is talked about a lot is affiliation. And that doesn't necessarily mean that somebody buys you. It doesn't necessarily mean that you merge with someone. There are a lot of different things on that scale of affiliation. It could be anything from a joint project all the way up to a full merger. So I've included in there just kind of a list of some different things that could happen. So this Heart and Stroke collaborative that you're part of, you're really beginning that affiliation. You're beginning those relationships with other folks. And so you're already really thinking about that. So I want to leave you kind of more on I mean, there are a lot of challenges out there. But like I said at the beginning, Kansas we're pretty scrappy. We're survivors. We will prevail in this process. We have a lot of people who are very, very committed to the healthcare in your community and across the state. We're the face of health. Hospitals are the face of health in our community. But it is also our responsibility to begin that coordination, that collaboration across the continuum of care within the community. Because all of us, all of the providers of service, from disability services all the way up to acute care, are definitely at risk in this new environment. So I think leaving you with a challenge, it's important to know where you fit, what kinds of things you're doing, and do a little bit of scenario planning. What happens if this happens? What should we do in that event? Or what are our options? Or what are the relationships that we need? How can we start some of those processes? Would they benefit us now to start them or not? So I think the challenge really is to learn as much as you can about the environment. It's always going to be, you know, it'll go down one path for a while and then it'll turn. It's just the way it has always been. So we do have to make sure, though, that we're paying attention to where things are going. So I will leave you with that and say thank you. Thank you to the Foundation Board for paying attention to your hospital and supporting your hospital. Thank you to the staff for being those folks that are on the ground trying to keep things going. And the community, those of you who are donating to the foundation, those of you who are just paying sales tax that is keeping that hospital going. So thank you very much. And I'm happy to answer questions if you have any, or have a conversation. Courtney?
I just have a question for you.
Sure.
I'm not sure how familiar you are with our hospital, but in comparison to other rural hospitals, how would you rank Emo Valley Hospital?
So we have hospitals that don't have any patients for 4 or 5 days at a time. I don't think you guys have that kind of issue. So you're not the smallest of the small. It's really hard to say without, you know, days cash on hand and all those kinds of things that folks look at. And I'm not even sure I'd be able to say. I just actually had a Washburn professor call and say, so how do we identify the hospitals that are sustainable so that we can place our students in a sustainable clinic or a sustainable hospital, so that when they get there, you know, 6 months after they get there, they're not going, I don't have a job anymore. And there is no formula. I'd say you guys aren't as at risk as some of our really vulnerable folks. But, you know, all it takes, as they say, all it takes is one crisis and things can happen. So I'm not sure I can answer your question. And if I did, I'm not sure it would be true.
Well, I'm on the board of trustees, so I know where we are, but I
Yeah.
don't know how in comparison where we are with the other hospitals.
Actually, you can do that. I'm sure you guys are participating in Quality Health Indicators, which is a benchmarking tool. And so you can actually benchmark on some of those factors with the other hospitals. So you could probably, you know, some of them you're going to be higher, some lower, and be able to identify those where you're lower and say, so what do we do to get those numbers up? And that's really what it was designed for, us to do exactly that.
Are they still looking at placing rural health facilities in, if you're so many miles from a metropolitan area, are they still looking at placing those in designation for not use or not be
Oh,
reimbursed or anything like that?
right now, most of our rural hospitals are considered necessary providers. That's really what you're talking about. And that means that if you're a critical access hospital and you have a rural health clinic, that you're allowed to do that. The federal government says you have to be 35 miles from any other hospital, it doesn't matter whether it's urban or not. And if they really were to come and enforce that, you all would be at risk for your critical access hospital status or your cost-based reimbursement. So things like some of these examples might be an option. And you know, that's really why you're looking at how do we have relationships, what do we do in the event of that. I have not heard anybody saying that they're going to remain. So I don't think it's a tomorrow kind of thing, but it sure could happen. And you know, we just have to be constantly vigilant about what's our plan B. Other thoughts?
Thank you so much, Melissa. I appreciate you taking the time out of your day to come talk with us. And like I said, we're going to be doing this quarterly, so if you guys have any topics that you'd like me to try to get to see if we get a speaker in here, please let me know. So, all right, if there's no other questions, you guys have a good day.
Thank you.